I've given talks about suicide and Huntington's disease before, mostly to healthcare professionals about prevention, but I've never given a talk about suicide to families. This topic cannot be discussed without recognizing that death is a spiritual experience, just as death is always an existential challenge to a person's sense of self, who we are, what they stand for, what they live for. Suicide is one way to die with Huntington's disease. In fact, 6 to 13% of people with HD died by suicide. It's the third leading cause of death. In the general population, for every one suicide death, there are 20 suicide attempts, and 200 people have suicidal ideation. Suicidal thinking is the symptom that characterizes severe major depression. Suicide with major depression or with impulsivity is somewhat preventable. Family survivors often experience complicated grief. I'm going to share a personal anecdote about how my unconsidered thoughts about suicide were first challenged. I was an intern in internal medicine at the University of Cincinnati, taking call in the intensive care unit. Our job was to use technical monitoring and invasive care to prevent death or bring people back to life. Sometimes it works, a lot of time it didn't. One night, I admitted a young woman who had taken a polydrug overdose. She took a combination of benzodiazepines like Valium or Xanax, Tylenol, and antidepressants. We hoped that was all she took. Before I went to bed that night, I checked on her. Her vital signs were stable. She was getting fluids and her kidneys were working. Her heart rhythm was normal. She was resting comfortably, asleep, but arousable. The next morning in the medical intensive care unit, we had rounds with our attending physician. We went from bed to bed, talking about recent tests or vital signs, current medications, or planned procedures. Everything was normal that morning. We were discussing the patient in the bed next to my patient, the young woman who had overdosed. Something looked off to me. I checked her heart monitor and her heart rate was 120. She was confused and beginning to move around in the bed, agitated. Her nurse went into the room, and I wandered away from rounds to see what was happening. She then developed an abnormal heart rhythm called ventricular tachycardia, a deadly rhythm, so we began to resuscitate her. Her morning blood levels returned, and her antidepressant levels were sky high. Then her heart stopped. We worked for over an hour, but we couldn't resuscitate her. All I kept trying to figure out was what had I missed? What had we all missed? She was so young. She was only 20 years old. One of my jobs as her intern was to inform the family. I called the number listed as her emergency contact, but that person told me she didn't live there anymore. I kept calling people to find her family and finally got her sister. Her sister's reaction to the news that she was gone was, "Good. She's finally dead. Good riddance." And she hung up on me. I was stunned. I had just spent 2 hours trying to find someone who cared about her death. It struck me that living with the knowledge that no one, not one person, cared that she lived or had died must have been awful to live with. What a heartbreaking experience it must have been for her to know that no one cared about her. It also struck me that if you lived a miserable life with no one in your life, maybe you created chaos wherever you went, or you pushed people away from you so no one could reject you, and you couldn't love anyone, what kind of a life was that? What kind of God would condemn her to eternal damnation under those circumstances? In retrospect, she had all the traits of borderline personality disorder. Most people with this disorder have traumatic childhoods marked by abandonment after abandonment. It was hard to treat. She was 20 years old. She would have had a chance with treatment if she hadn't died. On my way home that night, I kept trying to sort out my feelings. I had been taught that murder was a mortal sin, and murdering yourself was also a mortal sin, meaning you went to hell. In my heart of hearts, I just couldn't see that hell was a just sentence for this woman. For the first time in my life, I understood that suicidal people have a story, they have a life. Instead of being judgmental about suicide, I discovered compassion for people so desperate that they were willing to destroy themselves to escape a life they didn't know how to or couldn't fix. Since becoming a psychiatrist, I learned that suicidal thoughts are a symptom of major depression. If you have a cold, you have a stuffy nose, or maybe a cough, that's how you know you have a cold. For people with depression, suicidal thoughts arise as a symptom of severe depression. Suicidal thinking is not a childish attempt to manipulate others or a way to get attention. Suicidal thoughts and behavior are a deadly complication of a treatable disease, major depression. When people have suicidal ideation and or make a suicide attempt, that is the time in that person's life when they need humane and compassionate care more than anything else. So, what are the symptoms of major depression? Um, Sadness, stress, poor attention, trouble thinking or making decisions, poor attention, excessive guilt, loss of pleasure, pain, sleep changes, both too much sleep or not enough sleep, hopelessness, worthlessness, feeling irritable, weight changes, either gaining weight or losing weight, fatigue. In some people, Huntington's disease is a comorbid disorder. The most serious symptom of major depression, however, is suicidal thoughts and behavior. Approximately 70% of people experience HD related depression, and between 40 to 50% of people have had treatment for depression. This graph is from the PREDICT HD trial that includes gene expansion carriers who were followed throughout the course of their life. The PREDICT team measured suicidal ideation by stage of disease and found that the baseline for suicidal ideation across all stages was somewhat elevated. They also found two specific time periods when there were peaks of incidence of suicidal ideation. The first was during prodromal Huntington's or pre-manifest Huntington's, when people develop symptoms characteristic of HD but not definitive. So possible signs but not definitive. It's interesting that the rate of suicidal thought was lower after diagnosis than immediately before diagnosis. The second was during stage 2 or motor manifest Huntington's disease, when loss of independence and other vital adult activities like driving or employment were lost. Risk factors for suicide include drug and alcohol abuse, access to lethal means, stressful life events, and chronic medical conditions. Predisposing factors include neuropsychiatric conditions like Huntington's disease, family history of suicide, a prior suicide attempt, adverse childhood experiences, and just looking at socioeconomic standing or factors, male sex, living alone, social isolation, older age, chronic pain, and panic attacks are also associated with suicide. I've also learned that people who are considering suicide are often very ambivalent. A part of them feels that suicide is the perfect solution. The pain will be over, and even feeling nothing or not being anything would be better than the life they are currently living or the terrible pain they feel. The solution is seductive. It's something the person can make an active choice about rather than being a passive victim. But there's another voice saying, but what if death was not better? That it would be worse than this? Or I will be condemned to eternal damnation by God. Or I haven't tried everything I can do to make things better. Or what will my mother feel? My husband feel? My children feel if I do this? Who would find me? Would death be painful? Ambivalence can be life saving. It creates a moment when the person who is suicidal could hear a different voice, another person's voice saying, please don't leave. Your life is important to me. Please give life one more chance. This pause, questioning that any hope is left or for other options, is the foundation of suicide prevention. So, if you're in a room with a person you thought might be suicidal, what would you do? What would you look for? Well, you'd look for changes in mood. You'd see if they were giving away prized possessions or putting their final affairs in order. They might be withdrawing from the people around them. There might be a change in their physical appearance because they're not taking care of themselves anymore. Or they might be drinking alcohol or using drugs. If you're concerned that something feels different or wrong, it probably is. So trust your gut. Other signs to look for include high risk behaviors, making statements with themes of hopelessness, helplessness, and fear of becoming a burden, making verbal suicide threats such as, I want to die or I'm going to kill myself, or any other unusual out of character behavior. So the thing to do is talk about it. Talking about suicide does not increase the risk of suicidal behavior, it reduces that risk. Be non judgmental. Don't use the word should or but. Don't try to fix how someone feels or offer advice unless asked. Say, I would, I wonder a lot. Don't allow silences when the person is thinking about something. Remember that people with HD have speech latency. When you ask a question, it can take up to a minute or longer for them to respond. Just be with the person and be curious. Like I said, say, I wonder a lot. Most of all, stay calm, breathe, find your kind and most logical self. That's what that person needs, is somebody calm, cool, and collected. Finally, you need to ask the question, I wonder if you might be thinking life is no longer worth living. I wonder, are you having fantasies or fears about how you will die? Are you thinking about suicide? I have found that I can get a person to talk more openly if I lead into a conversation without using the word suicide immediately because of the stigma associated with suicide. Now you can talk about it. Ask about the details of their thoughts. Expect emotions. These are very painful thoughts and feelings. So someone might cry, they might get angry, they may feel very ashamed. Some examples of these details of the thought, including, I was driving by the bridge yesterday and the thought that I could kill myself by driving off the road came to me. I keep thinking about overdosing. I think about my father constantly. I have a morbid curiosity about joining him wherever he is. My family would live a better life without me. Stay with it. Keep talking about it. So, how intense is the thought? How often does it occur? How controllable is it? How much can you walk away from that thought and push it away? Does the person have a plan? Is there any intent to carry out that plan? And are there available means like a gun or knife or pills, etc.? It's okay to express how you feel. In terms of what to do next, now that you know the extent of the person's thinking and something about the risk of them acting, there are different things you can do. You can express how you feel about what they have told you. I hear that you are suffering, and I want to help you find a better way to live with your illness. I hear that it's hard to keep living with this. I know that you're thinking about what will happen if things get worse. Let's keep talking about this. Only you will know if it's the right strategy to try to convince someone to get help, or whether you are willing to risk your relationship with that person to get them help. Often, people that I have had to involuntarily commit to keep them safe are very grateful afterwards. The message was, I cared enough to do the hard thing. At a minimum, call and talk to someone on a suicide hotline for yourself. Share the burden with someone else who is qualified and impartial. The way you can segue to options for help is to say, in the meantime, would you be willing to help find out if there is something I can do? I need help, and I'd like to call a suicide hotline or a mobile crisis team. Here you are modeling self care and offering the person an opportunity to participate in their own self care. But definitely call a suicide hotline, whether the person agrees or not. Don't carry the burden alone. There are a number of resources that can help you. One is, like I said, call the National Suicide Prevention Lifeline. The other is to call a mobile crisis team. Each county in North Carolina has a mobile crisis team or a CIT team that will come directly to your home and evaluate the person to determine if they are okay to pursue outpatient care or if they need to be hospitalized. If you have just wrestled a gun or a knife out of somebody's hands and interrupted an attempt, call 911. That is your go-to action. You're going to need somebody there immediately. When everyone is safe, take care of yourself. Breathe. Do whatever it is you do to relax and calm down after a stressful event. Reach out to somebody. Take care of yourself. Safety planning creates a personalized crisis plan, including all the resources that you might need. Everything would be listed on this form. Put it on the refrigerator or another prominent place. It says, we are a family that's all about suicide prevention. Develop a safety strategy early in treatment when there's not a crisis going on, when nobody's depressed, when it's just life as usual, because then you can think through the different steps and collect the information that you need so it's available should you ever need it. It's like insurance planning. Intensive care in Huntington's disease is often as a consequence of pneumonia or infection, a fall-related injury, cardiovascular disease, or malnutrition. All of those may require intensive medical services and even resuscitation efforts. Treatment can be invasive and uncomfortable. If you find yourself in this situation, ask for a palliative care consult to sort out this experience. They'll help you go through your values and the values of your loved one and help you determine whether to continue that invasive care and give it one more shot or whether to let them go. When do you know that death is approaching? About 3 to 6 months before death, the person slows down or stops ambulating because of weakness. They slow down or stop eating because it's too hard to swallow, and then they lose weight. They may be severely fatigued. They may have discomfort or pain because they can't shift their position any longer in bed. Body temperatures fluctuate. Hospice is indicated in this stage of life earlier rather than later. When do you know that death is approaching soon? Well, typically people are bedbound. They may be confused or having hallucinations or talking to a deceased loved one. They may have an episode of aspiration pneumonia, which I think is a marker that the time is close. Many organizations now have the opinion that artificial nutrition is contraindicated in people with neurocognitive disorders like Huntington's disease because you're not going to make them better. It's not going to stop the progression of their disease. Hospice care involves medical care to help someone with a terminal illness live as well as possible for as long as possible, increasing quality of life. An interdisciplinary team of professionals address physical, psychosocial, and spiritual distress focused on both the dying person and the entire family. Medicare and most insurance plans cover hospice care. And the interdisciplinary team orders oxygen, medication, and other procedures to ease discomfort and symptoms. These interventions are used to ease suffering and neither hasten nor prolong death. So how can a person with advanced HD communicate their wishes for a natural death? Hospice services are not available until 6 months before a predicted death. So, at a time when a person has such advanced disease, they're often not able to make their wishes known. This is where advance directives come in. An advance directive allows a person who knows that they have a terminal disease to give advance directions so that their family and healthcare team can carry out their wishes. Let the whole family know who is the person with legal power of attorney for healthcare. It will help if that family knows your wishes. Advance directives are a broader part of estate planning, but it doesn't have to be. You can just fill out a healthcare power of attorney and living will. Or maybe if you feel that you need a do not resuscitate form, you can create one of those and carry it around with you in your wallet. Communicating about the dying process. People want to take the mystery and fear out of death and dying, and they want to talk about it. They want to talk about it a lot. So there's some tips for talking about death and dying at a put together by an organization called Choose Wisely. I've added their website here so that you can go to it. It's all about the method and the questions that are important to talk about or comments that you might have to make. What to talk about during the dying process? Four comments. I love you. I'm sorry. I forgive you. And goodbye. Saying goodbye is all about recalling those traits and memories important to each other. The traits and memories of the person who's dying, and the traits and memories of the person being left behind. So the final question is life worth living with HD? Each person must find a reason to get out of bed every day and find something to value about their life. Some call it having purpose, but I fear that places too much pressure on being productive. Some may call it being socially connected. But for the person with HD, I fear that places too much pressure on language and little respect for how much hard work goes into living in an HD body. Another way to look at it is having peace in just being, watching spring, feeding birds, holding hands, praying together, seeing children play, whatever peace is to you. So peace be with you as you journey through this life. And thank you for attending the 2021 HD Hive Education Conference.